Hi, good morning. Thank you. I really appreciate being here, also with some great colleagues and mentors, so thank you so much. My presentation is titled Predictors of Frailty Trajectories Among People with HIV. Next slide. Sorry. No. Okay, great. As a background, frailty is a syndrome of increased vulnerability to stressor that could be marked by a higher risk for adverse health outcomes, including usually poor health outcomes such as poor quality of life, disability, physical and cognitive impairment, and occurs as a greater frequency among people with HIV. In the context of aging and HIV, frailty can be defined using the frailty criteria that identify frailty as having at least 3 of the following criteria, such as exhaustion, weakness, low physical activity, unintentional weight loss, and slowness. As a dynamic condition, frailty can fluctuate with diverse factors, including comorbidities, also including HIV, hospitalization, and other life events. However, traditional longitudinal analysis often assume that all the individuals follow a similar pattern of change, not capturing the dynamic nature of frailty. And additionally, limited studies have sought to describe these dynamic changes or identify predictors of these changes in frailty, specifically among people with HIV. A potential solution for all these gaps can be exploring the role of latent class grown models in this type of research. So our study purpose was to estimate the latent frailty trajectories and identify corresponding predictors, including sociodemographic, HIV, comorbidities, and behavioral factors among people with HIV. We conducted a longitudinal design with data from the ACTG HALO cohort. Participants included people with HIV aged 40 years and older, and all the analyses were conducted on 976 subjects with available frailty data in at least 2 visits. The enrollment for all these participants occurred during 2013 and 2014 with semi-annual follow-up visits until 2020-2021. Our outcome measure was frailty using the frailty criteria, and as I mentioned before, the predictors that we used were baseline sociodemographic, HIV infection, comorbidities, and behavioral factors. The data analysis included descriptive statistics at baseline. Then we conducted latent class grown models in which we used frailty as a continuous variable based on the different frailty criteria from 0 to 5 the scores across 9 time points, and we conducted 5 exploratory models. After that, we conducted multinomial logistic regression model in which most likely class membership was used as an outcome using categorical variables. The characteristic of the sample at baseline included the mean age of 52 years. Most of the participants were men. 48% of the participants were white non-Hispanics. The years in ART were 9 years. 95% of the participants had an undetectable viral load, and most of the participants also had at least one comorbidity. The most common were hypertension, hyperlipidemia, depression, diabetes, and cardiovascular disease. In terms of frailty, the 55% of the participants were non-frail or robust at baseline, 39% were pre-frail, and 6% were frail. The most frequent frailty criteria for these participants were weakness, exhaustion, and low activity. This table shows the model fit information for all the 5 exploratory analyses that we conducted. And based on the model fit indicators, we selected a 3-class solution. This picture shows the different latent frailty classes. As you can see, we found one class that we named worsening frailty, represented by an 8% of the sample, in which frailty scores increase over time. Our second class was named sustained robustness, represented by most of the participants, 83%, and all the scores of frailty for this class were consistent over time. And our third class was frailty improvement, represented by a 9% of the sample, and you can see that frailty scores decrease over time. When we conducted the multinomial logistic regression, we found that older age, female sets having cardiovascular disease, using depressive medication, and moderate to vigorous and lower moderate to vigorous activities were predictors of being part of the worsening frailty class compared to the sustained robustness class. In the continuation of the results for this type of analysis, we found that older age, black race, female sets, lower CD4 count, the use of depression medication, diagnosis of type 2 diabetes, smoking, drinking, and lower moderate to vigorous physical activities were predictors of frailty improvement class compared to be part of the sustained robustness class. As a conclusion, longitudinal data made possible the modeling of frailty trajectories. We found one large group that remained non-frail over time. The 83% of all the participants were part of that group. And we also found 2 smaller classes with either improvement or worsening for frailty. Although the identified trajectories parallel some aspect of the frailty phenotype, they do not entirely overlap, reflecting different patterns of change in frailty over time that are not necessarily the 3 frailty categories: non-frail, pre-frail, and frail. Older age, race, sex, select comorbidities including cardiovascular disease, depression, and type 2 diabetes, and also some behavioral characteristics were associated with fluctuations in frailty over time in our sample. And this is super important because that can help us to identify interventions to optimize the management of all these factors to prevent or slow the progression of frailty among people with HIV. My acknowledgement to all my co-authors for this study, also to the ACTG group, and to the sustained training in aging and HIV research training support. Thank you so much.
Yeah.